Endocrinology Minutes with cyan. Hypothyroidism and thyroiditis. Classification. Permanent loss or destruction of the thyroid, such as Hashimoto disease or irradiation injury, is described as primary hypothyroidism. Transient or temporary hypothyroidism can be observed as a phase of subacute thyroiditis. Incidence. In the United States, 0.3% have overt hypothyroidism, defined as an elevated serum TSH concentration and reduced free thyroxine concentration, and 4.3% have what has been described as subclinical hypothyroidism. Subclinical hypothyroidism is defined as an elevated serum TSH level with a normal serum free thyroxine concentration. Etiology. Autoimmunity is responsible for over 90% of non-iatrogenic hypothyroidism in iodine-sufficient areas. Risk factors. A variety of genetic factors contribute to susceptibility in autoimmune thyroiditis, but epidemiologic data suggest a strong influence of environmental factors to explain the recent increase in prevalence. Non-genetic risk factors. Many of the factors that have been identified as increasing the risk for Graves' disease apply equally to autoimmune thyroiditis, such as pregnancy, drugs, age, sex, iodine, and irradiation. Pregnancy leads to the transient postpartum thyroiditis. Iodine and selenium. An excessive intake of iodine can precipitate autoimmune thyroiditis in susceptible populations. Drugs and smoking. A number of novel anti-cancer treatments, including the tyrosine kinase inhibitors, can also induce autoimmune thyroiditis. Irradiation. Radiation exposure has been shown to induce thyroid autoantibodies and autoimmune thyroid disease in a number of studies. Age. The prevalence of the disease increased markedly with age. Infection. The hepatitis C virus may precipitate thyroid disease in susceptible patients. Clinical presentation. Hypothyroidism can affect all organ systems, skin and appendage. Hypothyroidism causes an accumulation of hyaluronic acid that forms the non-pitting mucinous edema, which is apparent around the eyes. Anemia may contribute to the pallor. Hypercarotenemia gives the skin a yellow tint but does not cause scleral icterus. The secretion of the sweat gland and sebaceous gland are reduced, leading to dryness and coarseness of the skin called ichthyosis. Patients with hypothyroidism due to Hashimoto thyroiditis may also have skin lesions with loss of pigmentation characteristic of the autoimmune skin condition vitiligo. Vitiligo is recognized as a component of autoimmune polyendocrine syndrome. Cardiovascular system. The cardiac output at rest is decreased because of the reduction in both stroke volume and heart rate. Hypothyroidism is consistently associated with elevation of total and low-density lipoprotein cholesterol (LDL-C), and hypothyroidism is being recognized as a predisposing factor for non-alcoholic fatty liver disease. Respiratory system. Pleural effusions usually are evident only on radiologic examination. An increase in prevalence of obstructive sleep apnea is seen in hypothyroid patients. Alimentary system. Peristaltic activity is decreased, and together with the decreased food intake, is responsible for the frequent complaint of constipation. Ascites can occur, usually in association with pleural and pericardial effusions. Nervous system. Intellectual functions are slowed in thyroid hormone deficiency. Muscular system. Stiffness and aching of muscles are worsened by cold temperatures. skeletal system, calcium and phosphorus metabolism. Deficiency of thyroid hormone in early life leads to a delay in development in which the limbs are disproportionately short in relation to the trunk, but cartilage growth is unaffected. Urinary excretion of calcium is decreased. The exchangeable pool of calcium and its rate of turnover are reduced, reflecting the decreased bone formation and resorption. Because levels of parathyroid hormone are often slightly increased, some degree of the resistance to its action may be present. Levels of the dihydroxy vitamin D are also increased. Pituitary and adrenal cortical function. In long-standing primary hypothyroidism, hyperplasia of the thyrotrops may cause the pituitary gland to be enlarged. In severe long-standing primary hypothyroidism, pituitary and adrenal function may be secondarily decreased, and adrenal insufficiency may be precipitated by stress or by rapid replacement therapy with thyroid hormone. Reproductive function. In both sexes, thyroid hormone influence sexual development and reproductive function. In adult women, severe hypothyroidism may be associated with diminished libido and failure of ovulation. Secretion of progesterone is inadequate and endometrial proliferation persists, resulting in excessive and irregular breakthrough menstrual bleeding. Strategy for the laboratory evaluation of patients with suspected hypothyroidism. The principal differential diagnosis is between primary and central hypothyroidism. The serum TSH concentration is the critical laboratory determination that allows recognition of the cause of the disease. An exception is the individual with a recent history of thyrotoxicosis, in whom a low free thyroxine level may be associated with a reduced TSH level for several months after relief of the thyrotoxicosis. In patients with primary hypothyroidism, the absence of thyroid peroxidase antibodies raises a possible diagnosis of transient hypothyroidism following an undiagnosed episode of subacute or post-viral thyroiditis. In such patients, a trial of levothyroxine in reduced dosage after 4 months may reveal recovery of the thyroid function, thus avoiding permanent levothyroxine replacement. Treatment. Treatment consists of administration of thyroid hormone and correction of the associated physiologic disturbance. Because of the sluggish circulation and severe hypometabolism, absorption of the therapeutic agents from the gut or from subcutaneous or intramuscular sites is unpredictable, and medications should be administered intravenously if possible. The current approach to thyroid replacement using levothyroxine alone, although not a perfect replication of normal physiology, is satisfactory for virtually all patients. Alternatively, intravenous liothyronine may be given. Hydrocortisone 5 to 10 mg per hour should also be given because of the possibility of relative adrenal cortical insufficiency as the metabolic rate increases. Athyroidic patients who are planning a pregnancy should be advised to increase the dose of levothyroxine by around 30% as soon as the diagnosis is confirmed. The increased dose requirement persists throughout pregnancy, but dosage can return to normal within a few weeks after delivery. Myxedema refers to the appearance of the skin and subcutaneous tissues. The external manifestations of severe myxedema, bradycardia, and severe hypertension are invariably present. Besides the routine therapy for hypothyroidism, hypertonic saline and glucose may be required to alleviate severe dilutional hyponatremia and occasional hypoglycemia. A critical element in therapy is support of respiratory function by means of assisted ventilation and controlled oxygen administration. Internal warming by gastric perfusion may be useful, but external warming should be avoided because it may lead to vascular collapse due to peripheral vasodilatation. General measures applicable to the comatose patients should be undertaken, such as frequent turning, prevention of aspiration, and attention to fecal impaction and urinary retention. Thyroiditis. Thyroiditis comprises a large group of diverse inflammatory conditions, including autoimmune or quasi-autoimmune causes, and viral or post-viral conditions and infections, including those of bacterial and fungal origins. A chronic sclerosing form of thyroiditis, termed radial thyroiditis or STRUM, and miscellaneous causes of various types, including radiation-induced and granulomase causes such as sarcoidosis, as well as lithium. The most common cause of repeated childhood infectious thyroiditis, particularly in the left lobe, is a consequence of an internal fistula extending from the piriform sinus to the thyroid. Incidence. Infectious thyroiditis is extremely rare, with no more than a few cases being seen in large tertiary care centers. Clinical manifestations. The clinical manifestations of infectious thyroiditis are dominated by local pain and tenderness in the affected lobe or entire gland. This is accompanied by painful swallowing. Advertisement time. Welcome to the online replay of the just concluded forum organized by the Department of Endocrinology and Neurosurgery of Huashan Hospital, focusing on diagnosis and treatment of pituitary disease and sugar and home metabolism. The annual forum on endocrinology in our hospital will be held this weekend on September the 12th to 13th. There will be a live broadcast and you can scan the QR code to join us. Thanks for watching. If you enjoyed this video, just replay it. If you have any questions or suggestions, feel free to contact me through email. If there is the next episode, see you then!